Let me say that it is my true pleasure to be here with you today and have the opportunity to moderate these very important webinars that is going to discuss which is the status quo for the screening in lung cancer. So where do we stand, and which is the future? So in the discussion in the era of the precision medicine, how can we better think of refining the screening, the risk prediction, and using all the fantastic tools that are coming to our in our hands these days. And I'm particularly proud to have with us two distinguished speakers that I will introduce in due time. As I say, I'm a medical oncologist. I have no disclosure to no interest to disclose for today's purposes. And as a medical oncologist, I quite often have been asked why now all of a sudden you are interested in prevention. Why all this attention to prevention? And I want to make very clear that this is not all of the sudden. We had the opportunity in the past years with the society, the European Society for Medical Oncology, ESMO, to clearly state that if we want to successfully tackle cancer, there is no point of focusing only on treatment or on prevention. Cancer is a continuum, and as such, we need to treat him. It is clear that with respect to many cancers, lung cancer included, we have data that are clearly let us understand that this is a global problem, and as such we should deal with it. These are the data in terms of incidence and mortality from the Globocan in 2020, and unfortunately we can see from the forecast that the situation is not going to improve, with the number of cases expected in 2040, which is which exceed 1 million extra cases, and the same unfortunately is true for mortality. And sometimes it's true that well, not sometimes, it's true that we've made major advances in terms of understanding the biology of cancer, treating cancer even when it is in advanced phase, with many new drugs, targeted treatment. However, the substance of facts is that when we look at survival by stage of diagnosis, we can see that something that is a sort of also common sense, I mean, quite intuitive, that the sooner the cancer is diagnosed, the better is the prognosis and the probability of survival at 2 years and 5 years, and this is pretty clear from the data that I'm projecting. So the bottom line is that yes, we can do a lot for treating cancer when the cancer can not be prevented, but when lung cancer can be prevented, maybe we can definitely offer a better option for patients. So the question that I would like to discuss with my two fantastic speakers today are, does it make sense to screen for lung cancer? Which is the evidence in our hands? And again, in the era of personalized medicine, could we think or could we dream of a tailored screening plan for our patient? Then maybe it's not a discussion for today, but we really need also to start reasoning and discussing how to implement prevention measure and initiatives for all individuals in order to tackle inequalities that we witness with respect to treatment. So we don't want to repeat the same mistake. Maybe it's not for today's discussion, because for today, we want to take the luxury to review a science and data that then will allow us to change our practice. And once again, I took this opportunity to extend to all of you from me and on behalf of the European Society for Medical Oncology, the welcome to this webinar. And without any further ado, I would like to introduce the first speakers. I'm really pleased to introduce Professor Joachim Arz. Joachim is, has been the head at the Department of Pulmonary Medicine at the Erasmus University Medical Centers in Rotterdam, in the Netherlands, since 2018. His main research focus is on fundamental, translational, and clinical research in immuno-oncology, with a strong focus on lung cancer and mesothelioma. Professor Hertz is the leader of the core network on the mesothelioma and a board member of the European Reference Network on Rare Respiratory Diseases, ERN-Lung, and a member of the board of directors of the International Association for the Study of Lung Cancer. In his presentation, Professor Hertz has a very easy task. So he will discuss with us, will let us understand the latest states of affairs of the published data on lung cancer screening. So Joachim, the floor is yours. Joachim, sorry, Joachim, you need to unmute yourself.
That's that's a mistake. Yeah. So thank you very much, Rosa, for the very kind introduction and the invitation to speak here at this webinar. So I think we are all impressed by the numbers you showed us on the amount of people dying from lung cancer. So we must try to increase this survival rate. And as a disclosure, seeing patients dying of lung cancer almost daily, I can say that I'm really in favor of lung cancer screening. And when, sorry, these are my conflict of interest. And this is the evidence which is there. And these are the 3 largest trials published so far on the evidence of lung cancer screening. And what you can see here is the NLST, which is the US trial on lung cancer screening, including over 50,000 people randomized between low-dose CT scanning and a control arm, which in this case was a chest X-ray. And as you can see, the hazard ratio of that study, the relative risk of dying for lung cancer was 0.8. And in the Nelson study, which is the Dutch and Belgium study randomizing over 15,000 people, there was an intersection between males and females, and it was shown also in this study that there was a decrease in the risk of dying for lung cancer, both in men and in women. So this evidence is still out there, and we have to keep in mind that these are the results of studies. This is not clinical practice. These are clinical studies. And what you mostly hear from, for instance, this is from the US trial, is that it has been said there's a 20% reduction in lung cancer mortality when you apply lung cancer screening with a low-dose CT scan compared to chest radiograph. And as you can see here in the bottom slide is the cumulative number of lung cancer detected. And here is the number of deaths. And you can see that the decrease of the deaths of lung cancer is this 20%. But the question is this 20%? And I will come back to that later. This is again for the Nelson study. So hazard ratio of 0.74 in male, so saying a 26% reduction in the chance of dying of lung cancer. And for females, it's even larger. It's a 39% reduction in the chance of dying for lung cancer. And this is a wider confidence interval, which is due to the decreased number of participants. And I must say that those studies which I just presented to you are performed in heavily smoking patients. So these are heavily smoking patients, active or either stopped within something like 10 years ago, but having smoked before that a huge amount. So this is a very selected population of smokers. So again, given a reduction in the mortality in both those studies, but the question is this really this percentage which is the case? And we have to keep in mind, as I told you, that these are lung cancer these are screening studies. And what is happening in those studies is that you do a yearly CT scan. For instance, in this cartoon, you do a yearly screening on day year 1, year 2, and year 3. Sorry, this is the 3 should be on the 4. You do 1, 2, 3, and then you don't do any CT screening until you are going to read out your study. And this compared to the control arm where you don't do any screening at all. But what you have to keep in mind so is that you first do a 3-yearly screening, for instance, and then after that there's a period where no screening takes place. And then, of course, you get a dilution of the effect of your screening. And that's also when you can see in the US study, when, for instance, you look here after 6 years in the cumulative number of lung cancers, and when you compare that to what was seen after 3 years, so after the first three screening rounds, you can see that that is much more huge than it was here, because all lung cancers which are occurring in those patients after year 3 are no longer detected, as there's no longer any CT screening taking place. So what I'm trying to say is that the evidence of lung cancer screening and the cure rate of lung cancer screening would be higher when we increase the number of CT scans made. And that is also what is shown by the IICAP study, which is the study which is headed by Claudia Henschke from Mount Sinai in New York. And this is more or less an observational study where they do yearly CT screening and then observe what happens for patients. And what you can see in this study, that when you do the yearly screening, that they have a 5-year survival rate of 83%. So they almost cure every patient, and no patients are dying from lung cancer compared to the data which I showed you from the NLST. So it doesn't show you, it shows you that both those randomized studies show efficacy of lung cancer screening, but the exact amount of the benefit is higher than what we are now seeing based on this short interval of screening. And when you would continue the screening by yearly, and whether that's yearly or bi-yearly or 3-yearly, that's something which you will hear more about from Hillary, but that is going to increase the amount of benefit. And why is this amount of benefit there? Well, this is again from the Nelson study, and the amount of benefit is there because people, when they are screen detected lung cancer, they are mostly in an early stage. So they are mostly in stage 1 and 2, as you can see in this cartoon from the blue bars. So that most of those patients are detected in the early curative state, while in the control arm, which are the green bars, most of them are detected in stage 4. And as a comparison, in a Nelson study, there's also, we also applied the data which are there from the Dutch Cancer Registry, which is a nationwide registry where all people with cancers are included. And there you could see that the control arm performs the same as the cancer registry, showing that those data are robust in comparison to what we expect. But here we see again a huge increase in the amount of stage 1. And this is the graph which Rosa showed you in the beginning also, that when you look into patients who have a lower stage of lung cancer, so stage 1 and 2, who are curable, that the amount of patients who are cured is high. And when you get a metastatic disease, that we almost not were able to cure patients. So early detection is an advantage because at that stage you have more chance of curing patients. Well, there are things changing, and one of the things which is important to note, and these are data from Taiwan. It is a somewhat complicated slide, but I will walk you through. And what you can see here is the smoking rate in Taiwan, and that was decreasing. That is decreasing over the years. So this is this is very small, but this is 1990 to 2015. And what we can see here in the dotted bar is that the amount of smokers is decreasing. And here was a stop smoking campaign, so even a steeper decline, but still it's declining. And what you can see is that when you look into the light blue line, that is the squamous cell carcinoma, that at first there's an increase in squamous cell representing the smoking behavior of the people before the 1990s. And then here with this decline in smoking, given the time interval, we see a decline in squamous cell carcinoma. So squamous cell carcinoma is more smoking related. And when we get this decline in smoking, we get a decline in squamous cell. But sadly enough, what we see in parallel in the dark blue line is that there is an increase in the people who get an adenocarcinoma. So this is less smoking related. And what is seen in Taiwan and also in other Eastern or in other Asian countries is that there is an increase in the amount of lung cancer in non-smokers. And that, for instance, the question would be whether lung cancer screening should only be done in heavily smokers or also in non-smokers. And that is depending on where you are on the globe. Because what we came to appreciate that it's to get lung cancer is not only about smoking, but it's also about the genetic susceptibility. And what is found in people in Asia, for instance, is that there are more EGFR mutations in the lung cancer. And the concept is that EGFR mutations are more, getting lung cancer with an EGFR mutation is more present in non-smoking patients when you have this genetic susceptibility of getting this EGFR mutation. And it is now seen in Asia for about in 50% of the patients, there is an EGFR mutation. The other thing which we are coming to appreciate, and it could also be a combination of the two, is the increase in the air pollution. So around the globe, there is a tremendous increase in air pollution above the dangerous threshold, which is set by the WHO. And what we now are becoming more and more aware of is that the level of air pollution could have an effect on the incidence of lung cancer and may be related to this genetic susceptibility, which is there in certain people. And that's also what is shown here in this graph, that here you see the annual amount of air pollution. I'm not going to detail what this is, but this is an accepted figure on air pollution. And when on the vertical axis, there's the EGFR mutant lung cancer. What we now see is that the amount of air pollution is related to the presence of EGFR mutated lung cancer. So except for smoking, we are now going to see an increase in non-smoking patients, and potentially it's related to genetic susceptibility like EGFR mutation. So to conclude, I think we can say that lung cancer improves the outcome of patients. I didn't show it, but the first Asian study looking at lung cancer screening in non-smokers gives the same results, that also in non-smoking patients, you can get an early detection by applying lung cancer screening, which also is increasing the survival of those patients. Still, smoking cessation is important to decrease lung cancer rate. I think that is out of line, but we are learning more and more about the etiology of lung cancer, and this should also be applied in our further research on the prevention of lung cancer and also into the lung cancer screening. And with that, I'd like to thank you to your attention, give back the word to Rosa.
Thanks a lot, Joachim. Actually, this is a really interesting and interesting talk, and also I have a few questions in mind. Talking about questions, I would like to remind all of you that this is our webinar, our meeting, is our opportunity to ask questions, to discuss, to share comments. So please feel free to ask comment whatever you want to by using the question and answer chat. We want to address the majority of comments and questions during our webinar, and if not possible, we will do in due time. But this is really our opportunity to discuss, among us what this important team. And I already see that questions are coming. However, I think it would be much better to complete the introduction with the second talk, and then we will have time for discussion. So thanks again, Joachim. Now I'm very happy to move to the second speaker, who is Dr. Hilary Robbins. Hilary is an epidemiologist at the International Agency for Research on Cancer in Lyon, France, where she co-leads the integrative epidemiology team. She's originally from the US and trained at the Johns Hopkins Bloomberg School of Public Health and the US National Cancer Institute. Dr. Robbins' work is focused on risk-tailored approaches to cancer screening. So that's why she's here today, which doesn't make sense, actually, using tools such as risk prediction models and biomarkers. She co-leads the Lung Cancer Core Consortium, whose current project aims to develop and comprehensively validate a custom panel of protein biomarkers intended for use in lung cancer screening. So in her presentation, Hilary will discuss research developments in predicting lung cancer occurrence using statistical models, blood-based biomarkers, and artificial intelligence with low-dose computed tomography, so CT scan images. Hilary, I feel that I spoiled your presentation quite a lot, but I'm sure that you managed to tell us something the same. So the floor is yours. Thank you.
Okay. Hi, everyone. It's a pleasure to be with you. I will be talking about the future of lung cancer screening from the perspective of an epidemiologist, with a focus on risk prediction, biomarkers, and artificial intelligence. I have no conflicts of interest to disclose. And I want to start by saying that we really shouldn't need lung cancer screening. In fact, the need for lung cancer screening reflects a failure of public health policies for primary prevention. And of course, I'm mainly talking about tobacco control, because tobacco use is the strongest risk factor for lung cancer. And the target population for lung cancer screening is people who have a strong history of tobacco use. Any cancer screening program has to balance benefits and harms. So this is true for lung cancer screening, but also other types of cancer screening as well, breast, colorectal, etc. Of course, the intended benefit from cancer screening is that we prevent death from the cancer, but there are also potential harms which we have to work hard to avoid. And these include false positives, overdiagnosis and overtreatment, complications that can arise from diagnostic workup, as well as stress, worry, and anxiety that can come along with the screening process. And this is relevant because what we can aim to do is make screening more intensive for the people who are most likely to benefit. So in general, people who have higher risk for the screened cancer are more likely to benefit from the screening. And for those people, we can essentially screen them more intensively. At the same time, we want to reduce the harms for people at lower risk. And this brings us really to the idea of personalized cancer screening. And lung cancer screening is really a bit of a poster child for this idea. And the reason is that by using very detailed information about tobacco smoking history, we can predict lung cancer occurrence quite well, better than we can predict the occurrence of many other cancer types. So I'm going to try to lay out this idea in a bit of a cartoon. Let's say that we have someone who is considering undergoing lung cancer screening, and we need to decide whether they should be screened or not. So if we take this person at baseline, what we try to do is we estimate their lung cancer risk, because we know that if their risk is higher, then the likelihood that they'll benefit from screening is higher. And we can estimate this risk using different pieces of information: their demographics, such as age and sex, their detailed smoking history, when they started, when they stopped, how intensively they smoked. And we can also think about perhaps using information from biomarkers. We could take a blood sample and integrate that into our risk estimation. So the higher this person's risk is, the more likely they will benefit from screening. So using this risk estimation, we can decide, should screening be initiated or not? Let's say in this example that this person does decide to undergo screening. And after this initial screen, we suddenly have a lot more information than we did before, because now we have a low-dose CT scan. So what we want to do is we want to update our estimation of their lung cancer risk. On the low-dose CT, we can see all kinds of different things. We can see whether there are nodules in the lungs, and we can see different features of those nodules, their margins, where they're located, how big they are. And we could also consider at this point using information again from biomarkers and potentially applying artificial intelligence to the image or to all the information that we have. And so now we take all of this, we put it together, and we have an updated estimate of the likelihood that this person will be diagnosed with lung cancer either right now or in the future. So what we want to do now is use that to make different decisions within the screening program. For example, if the person has a nodule, we can decide how aggressively we should manage that nodule. Or if the person does not have a nodule in their lungs, or in general, they have lower risk, we can decide how long the screening interval should be. Should they come back for another screen in 1 year, 2 years, 3 years, etc. So this is the basic idea. Now, when we talk about eligibility for lung cancer screening, deciding who is eligible and who is not, I'm showing you a few examples from different countries around the world that are implementing lung cancer screening and how they decide who is eligible for the program. So if you look at the criteria in the US, Croatia, and Korea, we see that they use categories of age, pack years, and quit years. So in the US, for example, you're eligible for lung cancer screening if you're between the ages of 50 and 80, you've smoked at least 20 pack years, and if you've quit, it wasn't more than 15 years ago. If we compare this with what's used in the United Kingdom, they're taking a different approach, which is the use of risk prediction models. So here we take detailed information about someone's demographics, smoking history, etc., and we estimate the probability that they'll be diagnosed with lung cancer over a fixed time period. For example, here, 6 years for the model called PLCO in 2012. And if that risk exceeds 1.5%, then the person would be eligible for the screening program. To explain a bit more clearly this idea of risk prediction models for lung cancer screening eligibility, I have another toy example here. So let's consider that we have a 67-year-old female who currently smokes. She has smoked for 47 years, 10 cigarettes per day. She has normal BMI, although a diagnosis of COPD, and she does not have a family history of lung cancer. So what we do is we take all of this detailed information and we put it into our risk prediction model, and it spits out a number, which is the probability that she'll be diagnosed with lung cancer over 6 years. So for her, it might be about 3.2%. And we compare that with a threshold. So if the threshold is 1.3%, then she would be above the threshold and she would be eligible for screening. So this is the basic idea. Now, each of these different approaches to defining who's eligible for lung cancer screening has advantages and disadvantages. I'm going to summarize them in a quite simplistic way. So if we take the pack year and quit year categories, 20 pack years, 15 quit years, etc., this has the advantage, perhaps, of being simple to use, but in comparison with other methods, it has relatively low predictive accuracy for lung cancer. In comparison, if we use detailed prediction models for lung cancer risk, and we are sure that they perform well in the population of use, then they have much higher predictive accuracy. Put another way, we can screen the same number of people, and we will identify many more future cases of lung cancer if we use a prediction model. However, one concern with this method has been that these models may prioritize older and sicker people for screening. If this is the case, then it means that the number of life years gained from the screening program will be lower. In order to overcome this trade-off, one approach that has been proposed is to use prediction models for life years gained. So here, the model actually predicts the number of life years gained from screening instead of the risk of lung cancer. And this overcomes this trade-off between lung cancer risk and life expectancy. However, in general, these models are relatively new and they need further development and validation before they're ready to be implemented. So moving on to biomarkers now, this is quite a complex area of research. There are many different biomarkers that have been proposed for use in lung cancer screening. And you can think of this sort of as in the same way that we think of the other factors that contribute to risk. We would essentially want to take everything we know about a person, incorporate information as well from this biomarker, and put that all together to estimate the likelihood that the person will develop lung cancer. So in a way, it's just another piece of information, but in another way, they're quite complicated to measure and to use. So the different domains of biomarkers include, for example, proteins, autoantibodies, metabolites, DNA mutations, methylation, microRNAs, etc. All of these are mostly measured in blood. Another proposed approach is to measure volatile compounds in exhaled breath. So as you can see, there is quite a diversity of different biomarkers that we might use, a diversity of places in the body where we might measure them. And as you can imagine, this makes for a quite complicated situation when it comes to research. So in the context of research, I want to say initially that we have to think very, very carefully about how we design studies that are intended to identify and evaluate biomarkers for use in early cancer detection in general, but also for use in lung cancer screening. And I tried to summarize 4 kind of key considerations or things that we want to achieve. So first, we want to demonstrate that the biomarker can improve beyond existing prediction tools that we already have. So the information that we already have. And the reason for this is that measuring a biomarker requires a blood draw. So it requires something from the patient, and it also comes along with extra financial costs. So we need to make sure that it improves beyond what we already have. Secondly, we need to prove that the biomarker could actually facilitate earlier diagnosis of the cancer. And the best way to do this is to analyze samples that were taken prior to the cancer, so pre-diagnostic samples. Thirdly, it's critical that we use independent data sources to develop the markers and the algorithms, and then separately to validate the markers and the algorithms in order to overcome the optimism that happens when you develop and validate in the same sample. And finally, we need to aim to quantify performance of these markers in the full intended use population. So in lung cancer screening, if we're talking about people with a heavy smoking history, then we shouldn't be including, for example, never smoking controls in our study population. And at the end, we want to try to estimate what would happen if we implemented the marker in the full population. So if we kind of try to summarize all of this, what I like to say is that the study design has to allow the added contribution of the biomarker to be identified and quantified. I'm going to run through now a few examples of candidate biomarkers that have been proposed for use in lung cancer screening. And hopefully this may help you see how these different principles can play out in the real world of biomarker research. So the first example is the early CDT lung autoantibody test. And this was evaluated in a study in Scotland just a couple of years ago. And the design of the study was like this. There were participants who had a high risk of lung cancer based on their smoking history, and they were randomized to one of 2 arms. In the first arm, the participants were given the biomarker test, and the ones who had a positive result, which was a relatively low proportion, went on to be screened for lung cancer by low-dose CT. In the other arm, there was no biomarker test and no screening for anyone. So this was a no intervention control arm. And at the end, they compared the stage distribution between the intervention and the control arm. Now, the issue with this design is that we already know that lung cancer screening works. We already know that lung cancer screening has a very dramatic effect on the stage distribution of lung cancer. So even if this biomarker test were the flip of a coin, in other words, we just sent people to screening at random, we would expect to see a earlier distribution of lung cancer stages in the intervention arm compared with the control arm, even if the biomarker does essentially nothing. So this study design really doesn't allow the added value of the biomarker to be identified. It's not identifiable within the design, and certainly not quantifiable either. Another example is the Gallery multi-cancer test from GRAIL. This is one that's getting really a lot of attention at the moment. Of course, this is a multi-cancer early detection test, so it is designed to detect many different types of cancers at the same time. And I'm talking only about the results for lung cancer at the moment. So in their study, they evaluated the sensitivity of the Gallery test for lung cancer, stratified by stage at lung cancer diagnosis. And these samples were, of course, taken at the time of the diagnosis. So the sensitivity for stage 3 and 4 cancers was really quite high for this test. A small reduction was seen at stage 2, but the sensitivity declines really quite a lot when we look at stage 1 lung cancers, which is concerning because what we really don't know is, would this test be successful? Would it facilitate earlier diagnosis if we measured it prior to the diagnosis? Would we be able to move that diagnosis forward in time? So as of now, we really don't know the answer to this question. Another example is a microRNA signature classifier, which was recently evaluated in the BioMild study. And this was quite an interesting study because the individuals who were negative at baseline on the CT and also negative on the biomarker, so the double negatives, were sent automatically to a 3-year screening interval. And this is, I think, was the first time a 3-year interval was really used in the context of lung cancer screening. And it was impressive because it appeared to be safe. The risk in this group was very low at the end, and there were not, a large number of interval cancers or a large number of cancers detected at that 3-year screen. However, if we look at the biomarker itself, it didn't really seem to discriminate risk among the group of individuals who were negative on the CT at baseline. However, in the group of individuals who were positive on the CT, the risk over time between the biomarker positives and the biomarker negatives was quite different. So again, this is quite interesting, partially just because of the fact of this 3-year screen. And what we see is this potential utility of the microRNA biomarker among the CT positives. So to conclude on the biomarker topic, I'm going to tell you a little bit about our own work. This is done in the context of the Integral Project, which stands for Integrative Analysis of Lung Cancer Etiology and Risk. And this is an initiative funded by the US National Cancer Institute. Our study is designed in 3 major phases. So in an initial discovery phase, we scanned about 1,200 different protein markers for associations with lung cancer. We used blood samples that were drawn before diagnosis with an interval between 0 and 3 years prior to diagnosis. And in this discovery phase, we used a case control design, which was nested within 6 population cohorts. All of the participants were current or former smokers, so never smokers were not included. We used these results to identify 21 proteins to include on a customized panel, which has absolute quantification, and then proceeded through a technical validation phase for this panel. And at the present moment, we've moved into analyzing the data from our validation phase. So in the validation phase, what we do is actually switch from a case control design to a case cohort design. And this is important because it allows us to exactly reproduce the distribution of absolute risks among all of the current and former smokers in the cohorts, instead of trying to use the match controls to get back to this distribution, which is extremely challenging. The validation phase is quite big. It includes 15 cohorts. And again, their blood samples are drawn up to 3 years before diagnosis, and these are all current and former smoking participants. So we don't have results from this validation phase yet, but I will show you the results from our discovery phase. If you're interested in this, they are available on medRxiv. And we identified a number of quite strong associations with lung cancer risk in these samples, which were drawn up to 3 years before diagnosis, which is quite encouraging. And hopefully we'll have results from the validation phase soon. I want to conclude by mentioning artificial intelligence, because this is also, I think, going forward, going to be potentially a very important element of lung cancer screening programs. To understand why this is so interesting, you have to know that low-dose CT scans have all kinds of information embedded in them about lung cancer risk. So if we take nodules that we can see in the lungs, the location of these nodules is predictive of lung cancer risk, in particular the size of the nodules, but also the attenuation or the appearance of them, the type of margins that they have. And if we do multiple CTs, then we could see whether they're growing over time, which is extremely important. However, we can also see on the CTs, for example, emphysema, which is a strong lung cancer risk factor. And there are some other direct signs of cancer that can be visible, although rarely, including adenopathy and consolidation. So it becomes a real question whether, once we have an LDCT image available, if we can get all of the information out of it, would biomarkers be able to add on top of this information? And I think this is potentially going to be challenging. There's a lot of different algorithms that have been developed, and I can't show you all of them, but I will show you results from one. This was an algorithm developed in Oxford, and these results were published just a couple of years ago. And rightfully, the investigators in this study compared the performance of the AI algorithm with very well-performing nodule malignancy prediction models. So this is the same idea as a lung cancer risk prediction model, but here we're predicting whether a nodule is malignant or not. That's the Mayo and the Brock model shown here on these figures. So the development sample is shown on panel A, and then they had 2 external validation samples, which are shown in panels B and C. So you can see that it appears that the AI algorithm has higher predictive ability than the best nodule malignancy prediction models that we have. So going forward, we have to see exactly how these algorithms can be incorporated into screening programs and into nodule management. But it's a very promising area indeed. So a few concluding thoughts. I think that lung cancer screening programs can definitely be made more efficient and be made to have a better balance of benefits and harms if we personalize screening pathways based on individual risk. And clearly, biomarkers and artificial intelligence are very active and exciting areas of research to try to achieve this goal. However, we have to very carefully design and implement studies that can accurately evaluate the clinical utility of these tools beyond the standards tools that use the information that we already have. I want to say a big thank you to my team, in particular, Matthias Johansson, who co-leads the work on the integral panel with me, as well as the many individuals listed here. This is really a massive team effort. Thanks very much.
Thank you, Hilary. This was a very interesting introduction for all of us in the world of in the future with the tailored screening using biomarkers, artificial intelligence, and so on. So now I can see that both you and Joachim are already ready to answer the question that we are receiving, and I keep suggesting the audience to post the question in the Q&A chat box. There are already a few questions that now I'm trying to address to the speaker. So there are a few questions. One I can see from Kuldeep Singh Chauhan. And he's asking about family risk. So he's asking a very specific question: how much risk is there for a first order relative? But so more in general, I would be interested in for you, Joachim, maybe in touch upon the point of the family risk, if you can tell us about it.
Yeah, so I think it's really an evolving field in the research on lung cancer, because in the beginning we were thinking, of course, that those people who are in one family are also exposed to the same family conditions. So, for instance, when the father is a heavy smoker, then the wife and the children are also exposed to heavy smoking. So that would be the risk factor why they got lung cancer. But I think we are now getting to appreciate more and more that there is indeed this genetic susceptibility which is present in certain families. And we are really learning a lot from our Asian colleagues on the inheritance of, let's say, the lung cancer susceptibility, and that it's, for instance, what the data which I showed very shortly, but which on the EGFR mutation. So when there is this prevalence for getting an EGFR mutation in place, and you get another risk, let's say smoking, or another risk, air pollution, that will cause at the end of the day that people will get lung cancer. So a long answer to a short question. So I think it's really something which is now, unfortunately, the case, that it's more evident in certain families, and that we have not certain mutations we already know which are present, which lead to more lung cancer, but we have to learn much more from this.
Thank you. And yeah, Hilary, if you want to add something, and then I have a few questions for you. Yeah, please go ahead.
Yeah, maybe just to quickly say, while Joachim was talking, I pulled up one of the risk prediction models. So from a prediction perspective, the risk for people with a first order family history is about 80% higher than for those without, after adjusting for everything we know about smoking, age, etc. So this is specifically among smokers.
Okay, I think that there is a request for your presentation to add some details. So in the biomarker studies presented, what were the patient cohorts used? So example, 6 versus 15 cohorts.
Sure. So these cohorts, I didn't have time to go into detail, but they come from the Lung Cancer Cohort Consortium, which we coordinate. So these are population cohorts. They enroll generally healthy people, and at baseline, they take blood samples from the participants. They put them in the freezer. They collect detailed information on the individual smoking history, demographic information, health factors, and then they follow them over many, many years to collect information on lung cancer outcomes. So the cohorts in our consortium come from the US, Europe, Australia, and Asia. They include many, many different cohorts from, that are 20,000 people enrolled up to, 400, 500,000 people enrolled.
Thank you for the clarification. And then have another couple of questions. I found one of them particularly interesting. So also for you, Hilary. So Ibrahim Sulaiman is asking you, could your integral panel be beneficial to those who do not meet your risk prediction model requirements for screening? So for example, non-smokers with EGFR mutation.
This is an excellent question. And we can't answer it for sure, because all of the samples we've used to develop the panel came from people with a history of daily smoking. So we have zero data to say whether or not the panel would work in never smokers specifically. But this is a very obvious next step on our work, which we're kind of already taking. We know that lung cancer in people who never smoked is biologically quite different from most of the lung cancers in people with a smoking history. So we really don't know whether the same biomarkers would be predictive of lung cancer in this population. So it remains to be seen, but we're already working on it.
Okay, so I also say that to those who post the question, if you are not happy with the answer, you can ask follow-up question. So this is really our time, as I say. And again, I found this question quite provocative, intriguing. Hilary, is for you as well. So Olivier Leleu, so I hope that I pronounced well the name, say, in real life, can the use of biomarkers or risk model predictors reduce the participation rate and equity to access to screening by low-dose CT scan? So in my mind, I always thought of these are as an evolution, or, we can integrate, we can tailor and so on. But apparently there is, also different views. So there is competition between different ways of screening. So tell us about it.
Yeah, thank you very much, Olivier, for the question. This is a very good one. And like you said, there are different points of view on this issue. Maybe it's interesting to talk about the Manchester Lung Health Checks program in the UK, because this is, sort of known as the program that has around the world been the most successful one in engaging people of socioeconomic disadvantage. They had very high uptake in low-income populations. They came in for screening. They found tons of lung cancers. And they used a risk prediction model for eligibility, but the program was set up very carefully. And they have, quite an impressive workflow, if you will, for people calling in. You estimate the risk, you do it quickly, and they're eligible or not. They make an appointment, and they actually use mobile vans. The screening is done on mobile vans, so they're able to bring screening closer to people. So in this case, the risk model predictor doesn't seem to be a barrier to screening per se, but only because it's implemented very carefully. With biomarkers, it's an interesting one because I have encountered biomarker researchers trying to make the case that biomarkers will improve uptake. And I think in my personal view, it's a bit of a silly idea because we know that the problems with uptake are related to other things. It's because you can't get to the screening site. It's because you can't get time off of work. It's because it's expensive, so on and so forth. So indeed, if we aim to implement biomarkers, we have to be very careful at each step that we don't exacerbate inequities. And I think this really depends on who's paying for the biomarker. Does it require that people make multiple visits? Because that can be quite problematic, so on and so forth.
Okay, very interesting. Now, Joachim, I would like to come back to you because there are a few questions about the issue of any harms deriving from screening as it is. So harms of lung cancer screening. So this is a question that few of you asked. I'm reading the question from Laura Heavy and Julianne Little. Both ask about the harms of lung cancer screening, and is there a different harm in a screening patient who are smokers versus non-smoker? Joachim, can you enlighten us about it?
Yeah, of course, it's extremely important when you try to do screening and prevent things that you don't induce things. So it's one of the utmost important things to tackle. And I think there are a lot of issues. So the one is, of course, having, as Hilary also alluded to in her talk, having a positive scan without knowing what it is, and just having all the emotional stress of knowing that something is in the lungs where you don't know what it is. That's, of course, the first harm. The second harm is the fact that we are going to do interventions related to the found nodule, which could be not necessary. So that we have now learned a lot about nodule management, so that, for instance, in the US trial, there were a lot of almost 95% of nodules were, let's say, overdiagnosed and were resected when it was not possible. While, for instance, in the Nelson trial, by using an algorithm looking at volume doubling time, that this false positive discovery rate was much lower. So that's the other part, looking at the how to handle your nodules and integrating all kind of have a dedicated nodule clinic with a PET scan, for instance, and all those options which are there available, which may not be available for everybody. And so that's the one thing about the nodule management. And then the other thing is, of course, the let's say CT induced cancers, so that the CT by the radiation itself may induce cancers, which is present in a very low rate. And given the decrease in the radiation which can be applied for low dose CT scanning, it's even decreasing more and more. But I think it's important, it's really important also when people are followed up by CT scans, and when it's possible that you already start reducing low dose CT scan. So then, on the other hand, having a non-smokers, the chances that you are going to find anything are really dependent on where you are on the globe. So I was really impressed by the data from Asia, seeing how many people they are diagnosing with the lung cancer screening in non-smokers, and that could be totally different in another population. And so then you can do even more harm. So it's a long answer without giving the real clue. I think we are learning a lot in really having a dedicated nodule clinic with people who are really devoted to this diagnostics will decrease the number of false positives where you are going to do all kind of interventions. But still, we are eagerly awaiting the research by Hilary to help us, to guide us on treatment. That's, I think it's very important.
So no pressure there, Hilary. I mean, keep working. There is a lot of work to do. So I was thinking also, and again, I don't want to, I think that the discussion today, I would like to, this discussion to be focused on science again, because then, we always start from science and then implementing science into process and procedures. This is what policy has as a major aim. But Joachim, while you were talking about this dedicated clinic and so on, then I think that we need to reflect how this can be actually implemented in a fair way, in many countries that may have different level of economies and so on. But I don't want to be to talk about this, because I think that there is a lot still to clarify and to understand about science. So let's stick to science today. And a question for I think for both. You partly I think already addressed this, but just to be clear, Matthias Johansson, it is asking if it is conceivable to screen people who are never smoked, so never smokers, for lung cancer, and if their risk is high enough so that the cost-benefit ratio is favorable, and if not, which other factors can represent an additional risk for never smokers, sufficiently high, sufficiently risky to indicate, to provide the indication for the screening. Hilary, do you want to start?
Sure. This is really quite a challenge. And it is, because ultimately it would be ideal if we could offer the opportunity for early lung cancer detection to everyone, right? But the problem is that as risk goes down, the benefit goes down, and the harms are often still there, which means that the harms quickly outweigh the benefits when you get to people at lower risk. And for never smokers, for me, it helps to think quantitatively, right? So if we take this risk of 1.5% over 6 years, which is an approximate amount of risk that we want people to have to be screened, most never smokers are way below that number, 0.3% or something along those lines. So that makes it very challenging. The goal then becomes to find the ones who are actually at high risk, because they do exist. And so for the vast majority of never smokers, the answer is no. The risk is not high enough that the cost-benefit ratio would be favorable. But the question is, how do we find the ones who are at very high risk? And we haven't figured this out yet, in fact. And it's one reason why we're interested in looking at biomarkers. Another idea is to find people with symptoms, because diagnosis of lung cancer in never smokers is often quite delayed because lung cancer is not suspected. But there's not necessarily a clear way forward. And I think we also have to be extremely careful when making the assumption that the benefit of lung cancer screening that was observed in randomized trials of people with a smoking history would be portable to people without a smoking history, that benefit would also apply. Because in the data from East Asia, as Joachim mentioned, there's a strikingly high detection rate of lung cancer in these non-smokers, which I think surprised everyone. But there's also some data which are not foolproof, but that suggest that many of these cancers may be overdiagnosed. And that could happen because the biology of the cancers is quite different. And so really at the end, a big dose of caution is needed, I think. And if we move towards screening of never smokers, it has to be very, very carefully, very slowly, and ensuring that we only identify those people with sufficiently high risk that they could benefit.
Well, for the time being, I'm quite happy enough that we are moving for screening with smokers and individuals at high risk, So I totally share your comment about, again, moving based on science and cautiously to understand what is really beneficial to the population. And taking the opportunity of this webinar that, as we say, is basically, reporting the voice and attention from every corner from the world, I would like to take now the question from Usman Dieng, asking, in Africa, with the high incidence of tuberculosis, what about the sensitivity of low-dose CT scan screening? So I will start maybe with Joachim. Can you tell us about any interference of infectious problems with the low-dose CT scan? And then maybe Hilary can complement. I saw her, she's nodding. Joachim, would you like to start?
Yeah, I think it's an important point. As I told, it's depending on where you are on the world. What is the let's say the noise which comes with the screening? And on the one hand, it's the incidence in non-smoking patients. But here, when you have a high rate of tuberculosis, you will find a lot of nodules which have nothing to do with lung cancer, but have to do with, for instance, tuberculosis, can be histoplasmosis. It's depending on the part of the world where you are. So that really makes it more difficult to do your diagnosis. And to complicate it further, of course, we know that the tuberculosis can also be a risk factor for lung cancer. So that can also be additive. So I don't have the clear answer. I think it's, again, having dedicated people in your clinic who can help you to guide you how to best deal with a patient with a certain nodule. There's nothing wrong with a nodule, and just follow it up for some time and see whether it's growing or not. That is, I mean, something which, of course, when you have a tuberculosis nodule, there's no need to do PET scanning or whatever. When you see there's there's calcification, or you think it's a rather smooth border, then you can say, okay, I think it's tuberculosis. I just wait for half a year, 9 months, and do a new, well, it's depending whether you can do a CT scan or you're doing a chest X-ray.
Hilary, do you want to complement, or do you agree with Joachim?
No, that's perfect.
Perfect. So Joachim, you did a very good job in answering this question. So before going ahead, I want to report to you guys that everybody hugely enjoyed your presentation. So you're receiving a lot of thank you. Of course, nothing for me, but this was expected. Okay, so let's move on to the next questions now. So I found this very interesting one. There is a Melina Arnold. She's asking, I was wondering what is your view on the disappointing, between parentheses, low participation rates in lung cancer screening in countries where this is implemented. And she goes further by saying less than 10% of eligible in the US. So how can this be improved in the future? So how can we improve participation to screening program? Hilary, you were nodding. You are nodding. Do you want to take the word?
I'm nodding a lot. The questions are really good.
Yeah.
So in the US, indeed, we've probably exceeded 10% at this point, but in any case, the uptake has been low and slow to improve. And as I alluded to before, there are many different reasons for this. And ultimately, it's really a systems issue. It's not something that we're going to solve with the same mindset about personalization, in my opinion. This is really about systems, and how do we identify people who are likely to benefit? How do we convince general practitioners to encourage them to be screened? This is probably the biggest element, I would hazard to say, in the US, because no one's going to get screened unless their primary care doctor suggests it to them. How do we make it easy for them to come in? Because if they have to miss work and they're going to lose their job because they missed work, then obviously they're not going to be screened for this disease that they are unlikely to have, and maybe they're not worried about. And how do we ensure that there's not a financial impact on the participants? I'm talking a bit from the US perspective, because in the US, this is really related to, all of the myriad problems that we have with the US health system and its cost and access, et cetera. In a more generalizable perspective, there's data from different contexts that really emphasize the importance of centralization in screening programs. So it's not enough to say, okay, all of the GPs need to talk to their patients and encourage them to be screened. There really needs to be a dedicated person who's part of the program, who is charged with identifying people, contacting them again if needed, helping to solve their problems with transportation, cost coverage, et cetera. And after the result comes in, it doesn't stop there. Often they need nodule follow-up, or they need to come in 1 year and 2 years. And if there's ever going to be an impact on lung cancer mortality at the population level, all of those elements have to be put together. So the way to achieve that in the data that we have now seems to be that there's really someone whose job that is, right? To make sure that we find the participants, bring them in, and then bring them back over time.
Joachim, before moving further, so Hilary provided us with the more US experience. Do you want to add anything about this issue from the European perspective? So how can we improve the screening eligibility, not eligibility, but participation of the population to screening program?
Yeah, I think there's a lot of similarities, and there are a couple of things I want to add. One is, of course, the stigma, right? So I understood from the UK side that when they changed the name for lung cancer screening into the lung health check, that the uptake was higher just because it has another name on it. The other thing is that we have to raise a lot of public awareness about the fact that we can cure lung cancer. So I think in a lot of lower social income, people have seen relatives or neighbors who got lung cancer and died quite quickly. And we have to learn the general public that it's treatable when you're early. So a lot of this negativism on the faith of lung cancer is, I think, also really an important point. And the other thing is, just as Hilary was already mentioning, is the accessibility, right? Get the van coming near your supermarket or near the soccer game where you can do the screening in between is going to be helpful. But it's going to take a lot of a lot of public campaign also to get people aware of the fact that it's possible, that it's helpful, and it's not only giving you the stigma, you're a smoker, so we are going to look after you and you have to stop smoking. Stop smoking should be integrated in the screening system, but it's also getting all this negative stigma out of for the patient away, or for the patient. It's not a patient yet.
Interesting. Still, again, I want to stick to science, but then we really need, from your words, I think that there is really a massive work to do in terms of implementation of what we were saying today, which is not really a trivial job. It's quite tricky. So, of course, the science behind is pretty strong. So, this is a reason more to move forward, but still, there is a lot of work to be done. Now let's talk of validation. Colin Jacobs is asking an interesting question. So he's asking, for the statistical risk models for nodule malignancy, such as the Brock model, multiple rounds of retrospective validation in the end led to the introduction of this risk model into clinical guidelines. Do you think that similar retrospective evidence will be sufficient to implement artificial intelligence-based risk models, or do you think that we need to prospective validate them? So, Hilary, I think that it's about the validation of artificial intelligence contribution to this screening discussion. You see, Hilary, people really do not trust your word, right? They want to be sure. So you need to convince us.
Well, that's exactly what I want. Skepticism is actually critically important in this field. Thanks, Colin, for the question. This is a really tough one. And my feeling is that in the community at large, we will need prospective validation of AI algorithms. And what is the reason for that feeling that I have? I think it's because using AI, image AI, is sort of fundamentally different than using a risk prediction model as we have so far. And in the risk models that we have so far, we take some information that you could write on a piece of paper. It's a list. Age 62, 20 years smoked, 15 cigarettes a day, and you feed it into something and it spits out a number. And that process, with some reasonable assumptions, can be assumed to be portable. You can pick it up and you can put it down and you can do it at another place and expect the results to be fairly consistent with what you did in the first place, because it's a little bit hard to do it wrong. And perhaps, and you might disagree with me, in the case of AI, it's a bit different. We have an algorithm that we're putting down and we're feeding images into it. And those images were collected in a different place with a different machine, with different technicians. And the results from the AI output are going to need to be implemented by people in different places. So I think it's about the assumption that the approach we're evaluating is portable from the retrospective data into the current real world. And the research community was generally willing to make the assumption that risk models were portable from retrospective data into the real world. And maybe that was a good assumption or not. But with AI, there's perhaps some subtle differences where we will need to do retrospective validation, but then we will also need to do prospective validation to show that when we implement them in a program, we can use them to make decisions and that plays out the way we expect. This is really just my opinion, because I think that the question is a difficult one.
Joachim, do you want to add any comment on the very difficult question, or are you okay? Do you agree with what?
No, I think it's really, yeah, it is a really hard, it's a really tough one, and given also the developments which there were in the CT machineries, it's also the question how can you compare what has been done at that time to what is happening now. So that is, I think it's just to add to it, but I understand, of course, the fact that when you have to prove everything prospectively, it will take lots of time. And maybe one more. So I think AI is such a broad subject. So the question is, are we going to predict everything by radiomics, or are we first introducing, let's say, a more easy to accept AI features like speculation or calcification and add on top of that? So I think it's that we cannot say, are we going to trust AI based on, but just say we are going to trust AI detected speculation to say that this is a speculated nodule, which makes it more prone to be lung cancer, and thus do the workup in this patient. And when it's rather smooth, that you can say, oh, okay, I accept this smooth surface of the nodule, that we are going to increase the time between CT scans with a year or something like that. Maybe that's a way in between.
Yeah, there is a very, actually, yeah, there is always a way in between. So there is another quite broad question, but I think that we already addressed it with this comment, because they say how much artificial intelligence are effective and reliable in diagnosing cancer. I mean, this is a very complex, a very broad discussion, as Joachim was saying, possibly the specific question and the specific field where AI can be applied needs to be pre-specified, otherwise it's really too broad. But maybe we complement then offline. Something that I want to ask Joachim, I mean, you disclosed from the very beginning that, of course, because of your experience, research experience, clinical experience, you are very much in favor of lung cancer screening. So is there any actually conflictual results? Someone mentioned before in the question the MILE trial trial that deviated from the results from other trial. I didn't have this impression when I read it about it, but more in general, are all the majority of trials, the modern trials on screening, pointing towards the same direction? Do you want to make some comment about it? So how can we be reassured by the research done so far?
Yeah, so I think the data of the screening trials all support the implementation. It's just, I think the comment on the MILD trial was that it's a different setup of the trial, which then may also give a different result. But so I think in general, all the results point with the application of low dose CT screening point towards a benefit. But also we have to admit that we also are including only patients in whom you expect this benefit. So and that remains there, that we now are only are introducing it into the heavily smokers, at least in the Europe, from the European side, and the data which I showed. So that, let's say it differently, in those patients with high incidence, that's where we are implementing it. So yeah, that's what I
think it makes
yeah,
it makes sense, and this is something that is perfectly normal in what we are used to doing when introducing new intervention. In this case, is screening. It can be drugs, it can be whatever. So of course we try to define firstly to understand if there is any point in doing it in the population that is at higher risk, and then of course then the discussion may refine in population at different risk, and the benefit cost of the applied intervention may be different in different population, and the discussion with patients and also with governments can be different. So there is nothing new, so it's perfectly clear here. Hilary, you did a very good job, but you did not manage to fully convince Matthias Johansson, who is asking, so to follow up on prospective validation, does it need to be randomized?
No, I don't think so. This is an important point, because of course we needed, it was critically important that we had randomized studies to show that lung cancer screening results in a mortality benefit, that we randomize people to screening or no screening, and we look at the lung cancer mortality rate, and we see that screening reduces lung cancer mortality. That has been done, and it was critical to do that. However, as we move forward and we try to refine how we do screening, if you imagine that what we're trying to do is measure incremental improvements, this is sort of impossible to do in a randomized setting, because it would require an absolutely enormous amount of people to be enrolled, which would require an enormous amount of money, and it would also take a very long time. So when we talk about refinements to screening and personalization and this type of thing, sometimes we need to, it becomes very challenging. In fact, we need to do it prospectively so that we can demonstrate that it can be done. But when you implement something prospectively, you're also changing the natural history of lung cancer, right? Because you are intervening, you're screening, you're using biomarkers. So often you can't go backwards and say, what would have happened if we had not done that? And this is really the trick, is finding ways to design studies that we can say, this is what we did, this is the result that we had, and this is the amount by which we improved upon what we would have seen if we hadn't done that intervention. And as a result, sometimes the best answer is actually to do a study prospectively, but not use the novel tool to make any changes, and then go back and analyze the data to evaluate what would have happened had you used your novel tool. And then you can directly measure the impact that it would have had. So this gets into really careful thinking required to design these studies. But in any case, I think randomization is not the way forward. We use that to measure the mortality benefit, and beyond that, it's not incredibly useful.
There's an interesting comment from Martin Tamamaji saying about randomization is not required, that an historical cohort which were prospectively in data collection should work fine.
Yeah, so
that's true, right?
Yeah, it's perfectly true. I fully agree on that. So, Hilary, you are safe. There is no randomization to be made. I think that if there are, as Martin in his comments was saying, enough data, strong data, why we do not need to replicate just for the sake of replicating, all models. We can try to use new models. So now there are two interesting questions, and then I'm afraid that we have to close. One, I'm asking it for because I'm curious, I know nothing about it. So Ruta Everett is asking, are there promising results from the exhaled breath as a tool for lung cancer risk assessment for screening? Joachim, I saw you that you were nodding. Any comment about it?
I think we are learning a lot from exhaled air breath analysis, that it can lead to detection of a number of diseases, and certainly lung cancer would be very interesting. I think we have to learn how it is with small peripheral nodules where we are searching for. I mean, we don't want to early diagnose stage 4 lung cancer, so it has to do with the sensitivity. But on the other hand, it's easy to use, and because it's in the lungs, maybe it can be detected. There is already research ongoing and also published in early detection of lung cancer by the usage of the exhale breath. There are a lot of different machines for that in place. So I think it's really something which could be helpful to select patients to be screened or not in the future. It's not ready for prime time.
Okay, so I have another question. I think that we partly already answered that. Well, you partly already answered that, but maybe we want to make a short summary. So from an anonymous attendee, so outside of Asian population, how do we get never smokers into screening, given that the majority of smokers do not get lung cancer? How will it be cost effective? Will the benefit harm ratio still favorable? So for never smokers outside outside Asia, do you want to comment maybe again or to refine the comment, Joachim?
Yeah, so I think it's the open question. It's the ethical question. How do we not are we not giving the benefit to people who have never smoked and only for smokers? I understand the cost effectiveness, but that's something which we're not talking about as we're talking about science. So I think really here the biomarker issue would be extremely helpful, that we can select people that they are more prone of getting lung cancer. So please go for lung cancer screening. And that will also help to the acceptance rate. I mean, there are certainly, for instance, in the European Union, recently it was decided not to implement screening on a large level. So even for heavily smokers, so when we are expanding that would even be more difficult. But on the other hand, I still think as a clinician and seeing patients also who were never smokers who didn't get the chance for screening makes it also, well, really sad to see. So
okay, thank you, Hilary. Do you want to add anything? Do you agree with Joachim?
Yeah. No, yeah, I answered it before, I think.
That's fine. So now I think this is the very last question comments that we can. Well, now I actually have one question and one comment. So Sebastian Gendarme is asking, could we expect a benefit from expanded screening for cardiovascular disease and COPD? So
yeah, well. It's interesting, of course. That's something which we didn't touch on, that you also, when you do a lung cancer screening or a low dose CT screening, that's the word I must use, that you also are going to find additional comorbidities like COPD, emphysema, coronary artery disease. So you're going to find a lot of other ways. There's also now, you may also detect early breast cancer by giving the low dose CT scanning. So it's a two-edged sword, I think, that the lung cancer screening can also add to earlier diagnosis of other diseases.
And now I would like to, this is very the last comment, and anything else that is posted in the chat, we will be back in due time. And so, but, you know, I hope that this webinar was followed by, has been followed by many, and in particularly, I wish from many young colleagues, students, younger generation, and one of them, Ibrahim Sulaiman, is asking, what advice do you have for an early career researcher considering to move into lung cancer research, with special interest in minimally invasive lung cancer biomarkers? And I would like maybe a very, you know, short word, or brief word of wisdom from both Hilary and Joachim. So what is the advice for this young colleague to move into research in the field?
Well, I guess I'm trying to think of any advice that's specific to being interested in minimally invasive lung cancer biomarkers. I guess the only thing I would say that's specific to that is that I feel a bit working in this field that there's 99 ways to do your study wrong and one way to do your study right. And so being extremely careful about how you design your research and talking to people with diverse sets of expertise before you do anything can save you a lot of strife, I suppose. And, you know, in general, early in your career, it's important to, you know, find the right mentors and sort of bounce your plans off of different people, because I think the most difficult thing about a research career is the transition from PhD to postdoc, and then from postdoc to, you know, assistant professor level things, and then trying to fund yourself and move forward. And it's extremely challenging for everyone. So
that's okay, Hilary. We do not have to plan the career. I just want to add that it's very important to say what Hilary says, that I fully subscribe. It's very important partnership. And what we have today is a wonderful example on working together with, you know, not only between two very important society, very important groups, so HIARC and ESMO, but also have the opportunity to have this discussion all together. And I think this is the best way to do everything in anything in research and in life. So so I think can I just ask one very last comment about lung cancer screening with respect to your field of application to Joachim and Hilary, and then my final remarks in 30 seconds, and I will give back the word to the floor to Dominique. So Hilary, what your final last remarks about what we discussed today?
I guess I will just reiterate that we have to do good research. And in order to do good research, we need to work together, and we have to be genuinely interested in deciding whether these tools are useful, and not each of us in our own corners trying to promote our own thing.
Thank you so much. Joachim.
Yeah, I agree. And I also think it's, on the other hand, it's also important that we try to unite and also use that into how we are talking to our patients, and also talking to the policymakers, because they are all going to, when patient is hearing different stories from different scientists, he's also not knowing what to believe.
So my very last remark is that, so first of all, I want to thank the speakers, a fantastic presentation, and they very timely addressed the very difficult question, I think an interesting question that we had. I really want to thank my society, ESMO, for the opportunity to co-develop this webinar and the opportunity to share in it, and HIARC, many people behind this organization, but most most than anybody else, Dominique, that is with us today and that actually has to put up with our schedule time in chasing everybody. So thank you so much. I just want to conclude before giving the floor to Dominique about what Joachim, listening to what Joachim says. So I always say that policy is the application of science. So today we had a wonderful example of what science has already produced as data to be implemented to promote health for individuals all over the world. Now the next steps is to refine what the work that has been already done with new interesting tools that Hilary talked us about, but also to find a way to bring this science to individuals, because otherwise, I mean, just discussing science for science is really good, it's really fun, but we want to improve outcomes for every single individual on this planet. So we need to work together to implement the wonderful science that we discussed today. And I think that everybody is ready to do his own bits. And having said that, now I give the floor back to Dominique.